Hello, I'm Dorina Landa, and I'm the Executive Director of Advancement at the Temerity Faculty of Medicine and Assistant Vice President for Advancement Relations with Healthcare Institutions at the University of Toronto. I'm so pleased to welcome you to this latest installment of our Temerity Medicine Talk series on the topic of planetary health and its intersection with human health. Before we begin, I would like to take a moment to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful for the opportunity to work on this land. In today's talk, Healthy Planet, Healthy Lives, Climate Resilience, and Sustainability in Healthcare, we will further reflect on the relationship we have on this land as citizens of the planet and as healthcare professionals. There is no doubt that the effects of climate change are impacting human health, but what can we do about it? How can health education, health research, and the healthcare sector at large contribute to a healthier and more sustainable future for all? We will soon hear from a few U of T experts on examples of actions being taken and opportunities for further impact in these times of climate uncertainty. I do hope you enjoy today's discussion and look forward to welcoming you to future Temerity Medicine events. In the meantime, I'd like to welcome Patricia Houston, Interim Dean of the Temerity Faculty of Medicine, to say a few words.
Thank you, Dorina. It is my sincere pleasure to welcome you to this Temerity Medicine Talk. As many of you know, the University of Toronto and the Temerity Faculty of Medicine are the hub of Toronto's world-renowned academic health sciences network. This network of clinicians, researchers, educators, and learners on campus and in our affiliated hospitals and research institutes work collaboratively to develop innovative solutions to the world's and medicine's biggest issues. Their impact can be felt across Canada and around the globe. Our Temerity Medicine Talks are one way that we can highlight some of these impactful initiatives. Today, we'll be talking about climate resiliency and sustainability, which has become an area of focus at Temerity Medicine in the last years. As clinicians, researchers, educators, and many of us, alumni, we recognize that climate change touches all aspects of delivering healthcare and conducting our research. It's imperative that we prepare our learners to take on leadership roles in responding to and fighting climate change now and into the future. I'm proud and excited for you to hear from faculty members and other experts from U of T on how we are supporting this goal and how we are having in our communities an impact as healthcare practitioners. I'm also pleased to have Andre Picard, the award-winning health columnist for the Globe and Mail, here to help guide today's conversation and discussion. Andre, thank you for being with us. And now I'm going to turn it over to you to further introduce today's topics and our speakers. Thank you.
Thank you very much, Patricia. As mentioned, my name is Andre Picard, and I'm thrilled to host the Temerity Medicine Talk on climate resistance and sustainability in healthcare. The health of our planet and the health of its people are very much intertwined. As the Earth's climate changes, we're seeing the devastating impacts around the globe, from wildfires to massive floods, and increasing spread of infectious disease and malnutrition. And it's only expected to get worse. In fact, between 2030 and 2050, the World Health Organization estimates that climate change will cause approximately 250,000 additional deaths annually, and that's from illness alone. How is the healthcare sector responding? What's the role, and what should be the role of practitioners in helping mitigate this crisis? Those are some big questions, and today we'll hear some answers from 3 U of T experts who are doing work to mitigate climate change. While their full bios can be seen in the description below on the screen, let me briefly introduce them. I'll start with Dr. Samir Gupta. He's an associate professor in the Department of Medicine, as well as a respirologist and clinician-scientist at the Shing Knowledge Institute at St. Michael's Hospital. He also holds the Michael Locke Term Chair in Knowledge Translation and Rare Lung Disease Research. Welcome, Samir. Next, we have Dr. FIONA Miller. She's a professor at the Dalla School of Public Health and chair of its Health Management Strategies in the Institute of Health Policy Management and Evaluation. She also chairs the research subcommittee of U of T's Committee on the Environment, Climate Change, and Sustainability, and is an associate director of the university's Climate Positive Energy Initiative. Welcome, Fiona. And finally, we have Dr. Ross Upshur. He's a professor in the Department of Family and Community Medicine and the Dalla Lana School of Public Health, where he's the chair in clinical public health and head of the Division of Clinical Public Health. He's also a senior scientist at the Lunenfeld Tannenbaum Research Institute and a staff physician at the Hennick Bridgepoint Hospital, both with Sinai Health. Thank you all for joining us today. Should be a fun discussion. So let's get right into it because it's a very small topic. So Dr. Samir Gupta, if I could start with you, let's start with a little bit of context. Can you give us a little bit of a sense of the health impacts of climate change, both on individuals and communities, sort of the view from 30,000 feet, if you will?
Sure, Andre, and thanks to Temerity Medicine for having me and for hosting this. It's a big question, even to give an overview. You know, there are so many different impacts of the changing climate on human health. The first one is just the heat. You know, we had just recently the Lancet published its 8th report on climate change and health, and every year it seems it gets worse, it gets more scary. And this year was the hottest year on record in 100,000 years. If you just look at temperatures, they're talking about, compared to 20 to 40 years ago, double the number of extreme heat days. So it's not just that mean temperature, but it's these extremes of temperature. It's these heat waves. And the result of that is in the next 25 years or so, we're looking at a 5-fold increase in the number of people around the world who die just from heat exposure. And you know, we're a cold weather country, but we're not immune to that. We often worry about people who are underhoused, who are on the streets dying in our cold weather. But many people died within their homes last year when we had that heat dome effect in BC. We've had heat waves this summer in Quebec and Ontario that were deadly. We had school closures in Quebec in September. So this is affecting us as well. So that's where I'll start, with just the heat. But I'll also mention, and because this has been in the news a lot, that we're seeing diseases and more of certain diseases than we ever have before. And that has to do with how the changing climate is impacting habitats for certain animals that can cause what are called zoonoses, or diseases that come from animals over to humans. And for certain vectors. Vectors are things like mosquitoes or ticks that carry often those infections over to humans. The big one is Lyme disease that we hear a lot about, and there's more and more Lyme disease, presumably because those ticks are able to survive longer through our winters and are in greater numbers. And so people are getting bitten more and getting infected more. But there are other things too. There's a tick-borne illness that's not an infection called alpha-gal syndrome. We're hearing more and more about this in the United States. Very scary. It's actually an allergic reaction to something called alpha-gal or alpha-galactose, a type of sugar in the saliva of the tick. And if you get an allergic reaction to it, you actually become allergic to red meat. And so we're seeing this wave of thousands of people becoming allergic to red meat in the United States. And it's because the tick that causes this, the Lone Star tick, is moving up further and further as the climate changes. And the last one I'll mention is malaria, only because this year the CDC reported 4 cases of malaria caught locally, local transmission. You know, this is not someone who traveled to Africa or Asia. This is Texas and Florida. You know, it's not where you think people can randomly catch malaria. So it's all of these diseases, some of them things we think of as tropical diseases, that are becoming common and that are coming to our shores as things warm up, and these animals and these vectors are able to survive in our climate. And the last one I'll mention that's really important and really topical because of what happened this summer is where climate and pollution interact, and that's wildfires. The conditions for bigger, longer, more significant wildfires are created by climate change, but those wildfires then create a massive impact in terms of pollution. And of course, there are so many effects of that pollution on human health. So I think those are 3 big ones, Andre. There are many more, but 3 really important ones that are happening right now in Canada.
And the wildfires you mentioned, those were really a wake-up call for Canadians. But you're a respirologist. Did you see that more direct impact on your work? I imagine it affects people with asthma and COPD, fires and smoke, people with allergies. It must be bad.
We see a huge impact in respiratory medicine. We see what the studies tell us we will see. When these events happen, we see a dramatic spike in emergency room visits in patients with underlying respiratory conditions. things like asthma, which is very common, things like COPD or chronic obstructive pulmonary disease, which is a chronic lung disease. People tend to flare up. They get what are called exacerbations. They can get quite sick. It's all that particulate matter, those we call PM 2.5 or particulate matter that's 2.5 microns or smaller, 2.5 thousandths of a millimeter, that comes out with these forest fires. And it's small enough that when you breathe it in, it goes all the way into the alveoli, or the air sacs at the ends of the lungs. And that can be very irritating to the lungs, but it also gets absorbed into the bloodstream, Andre. And there have been many studies showing that when you have these forest fires, you also see a spike in things like heart attacks. You see a spike in things like strokes. You see increased susceptibility to certain infections, including several studies that showed more COVID after these events. So there are all sorts of different things that happen that affect human health, but definitely we get a lot of phone calls. We have a lot of patients who are sick and need to be seen when these kinds of events happen, and we're giving them all sorts of advice, often by telephone, often just ad hoc, around how to mitigate their risk when the environment changes so quickly around them.
Now, Professor Fiona Miller, we heard from Dr. Gupta a lot of impacts on human health that affects clinicians, but the healthcare sector itself also contributes to climate change. I read it's responsible for about 5% of the world's greenhouse gas emissions, for example. How can the sector clean up its act, maybe lead by example, among other things?
Well, it's true, isn't it? It's one of the great ironies that a sector designed to heal and to support health is in fact responsible for a remarkable amount of resource depletion and pollution, as you say, about 5% of global greenhouse gases that healthcare is responsible for, not just through our buildings where we tend to think it resides, but really in the products and services that we purchase and that we use. But it's also other environmental contaminants. It's definitely air pollution, responsible for up to 3.5% of some of these air pollutants, as well as plastics, as well as other environmental risks, for example, through our pharmaceuticals. And so because much of this pollution is in fact embedded in the products and supplies that we use, it's embedded in the way we provide care and the types of care that we provide. So cleaning up our act, as it were, is in part about trying to change some of the products that we use or the way we provide services, but also thinking more deeply about some of the longstanding reform issues that we've long wanted to advance in healthcare. And I'm a health policy professor, and the reason why I got engaged in this work is really because a lot of what we're trying to change aligns with reform imperatives that we've been working on for a long time. So we need to have a more primary care-led system. We need to have a system that connects effectively to social care, that supports community health and well-being, that is high touch, that provides that opportunity for strong patient-centeredness and empowered patient and client decision-making, as well as, of course, avoiding duplication and unnecessary or low-value services. We unfortunately do, in fact, deliver a proportion of care that is of low value, by which I mean it's care that is very unlikely to produce a benefit, but nonetheless exposes that person to potential risks, because all of healthcare comes with some risks. So you're providing a service that it may in fact cause harm, that is certainly using up human resources, time. It may be getting in the way of providing high value care, and it is generally going to be a net environmental loss as well. So there's all these kinds of things that are part and parcel of improving the environmental footprint of healthcare. And I think in doing so, we are both having a direct impact on the problem and improving the health of populations worldwide and contributing to that, but also trying to leverage our power as a social institution, major market shaper. Some of the things that we use that are contaminating are in fact what healthcare is exclusively responsible for. So it is our job to shift those markets, to remake the way in which those products are developed and deployed. And I also think to be part of a broader shift, I think, in social awareness as a very powerful and important social institution.
And you work with a program called Cascades that works in this field. Can you tell us a little bit about that work?
Sure, Cascades. So this is an initiative funded by Environment and Climate Change Canada. It's a 5-year initiative for climate action and awareness in healthcare that we here at U of T run in collaboration with colleagues at the University of British Columbia and Vancouver Coastal, colleagues at Dalhousie University and the Healthy Populations Institute there, and also a national NGO that's been doing this work for about 20 years, the Canadian Coalition for Green Healthcare. So we really, I'm a researcher, but this isn't research. So this is really an evidence to action network that we do have boots on the ground across the country, or at least in some, in British Columbia, in Nova Scotia, and in Quebec, and in Ontario. But we work with colleagues, both clinicians, administrators, senior leaders, really across the country. And we help support the development of implementation-ready resources. So there is good evidence on some of the clinical practice changes, and Dr. Gupta can talk about some of those, and the clinical guidance that comes forward. So what we try and work on is more of that, well, how do you do it in practice? Because people need to know, if you're going to change a prescription, what's routinely available to patients in your province, what's covered. You're going to need to know that. What do you run in your EMR to search whether your patients have the kind of prior diagnoses that might be relevant to this? We do that. We run courses and events, and we do some very intentional pan-Canadian networking. We're doing some work. We did some work around, and are continuing to do work around, how the healthcare organizations, provinces, and territories estimate the greenhouse gas emissions that they produce or are responsible for. How can we move towards more in a very collaborative pan-Canadian way? How can we do this consistently? We're doing work around that on things like sustainable procurement, and we try and connect clinical leaders around the country. So it's really that leveraging the real growth of expertise and engagement that exists out there, and then trying to help folks not reproduce the wheel entirely, but share the resources and capacity.
Okay, and we'll talk about some of those things coming up. Dr. Ross Upshur, thanks for your patience. We're finally getting to you. You've been doing environmental health research for a long time. For example, years ago, you studied the disappearance of the Aral Sea, I think in Uzbekistan. That was one of the worst man-made environmental disasters of the century. Can you tell us a bit about this experience, some of the lessons you've learned going forward from that?
Yeah, thanks, Andre, and thanks to Temerity Faculty of Medicine for inviting me, and it's a pleasure to share the floor with distinguished colleagues. So the Aral Sea is probably one of the more sobering experiences I've had in terms of trying to get one's head around how human economic and extractive activity. There's a long narrative here to why the sea disappeared. It has to do with growing cotton in the desert and irrigating the desert to grow that cotton at such a scale that so the Aral Sea was once the fourth largest inland body of water, larger than all of the Great Lakes except Lake Superior. So imagine over a 10, 20, 30-year period, we could walk from Toronto to Rochester. Because Lake Ontario had disappeared. And what the lesson is so it did create climate change. So it wasn't necessarily related to carbon footprint or fossil fuels, but it was related to human economic activity, fundamentally, profoundly, and irreversibly changing an ecosystem. So it actually created the disappearance of the water destroyed culture. It created economic refugees. It created a massive air exposure because of the creation of dust. And essentially you were witnessing what I would call ecocide, the intentional destruction of nature by humans to make it fundamentally unlivable for future generations. So to me, that was not the sort of thing you wanted to see more of, but actually, it's actually exactly what we're seeing with now climate change, with global warming, and with profound changes to all facets of the natural world. We tried our best to characterize those health impacts, but these are very complex situations. We made some progress, but we were hampered in how far we could go because of certain realities that occurred in the geopolitical sphere, which I will not bore the audience with. So, two things to note. One is that our capacity to, clothe ourselves and feed ourselves and to live the lives that we like to lead actually holds within it the keys to our potential destruction. And if we're not wise stewards of our natural resources, we face a peril that I think we're not well prepared for. And interestingly, there was a new report in the, Secretary General of the UN warning that we're on a collision course to crash past 3 degrees of warming, and what he calls a hellish scenario. So we're in a very difficult situation and need to take concerted effort soon. I've seen what happens. It's not very pretty. So, I hate to be the depressing one on this conversation, but we're dealing with very substantial, serious, and potentially lethal permanent consequences.
You have some competition there in the depression department, but that's not all cheery stuff. But I want to wade into another area where you have an interest, ethics, bioethics. As I was listening to the other two speakers, I was wondering, do physicians, do healthcare workers have a moral obligation to fight climate change?
Well, that's a fascinating question, Andre, and one that I've turned my thoughts to over the years. So typically, if you look at codes of ethics for health professionals, be they physicians, be they nurses, and I was actually part of the group that revised the most recent Canadian Medical Association Code of Ethics and Professionalism, all of the obligations are to humans. There's nothing in any of the medical ethics that obliges us to care for, non-human entities such as nature. Now, there's a long tradition in environmental ethics where people have thought through what it would be for humans to take a less anthropocentric view of the world and to sort of, actually this dates back to the mid-19th century, where people started to get really enthused about, being nice to plants, for example, in 19th century German philosophy. But I think what I've seen in the literature is there's a claim that health professions have an obligation to help protect the environment, and this needs to be elucidated and discussed, and I think entered into codes of conduct and codes of ethics. I think it's a really important area for current and future scholarship, because it's easy to say, people love to claim that people have moral obligations, but moral obligations need to be grounded in something. And currently, where a health professional's obligation would be grounded is unclear, and I think that needs immediate attention, to be honest.
Well, it sounds like a bit of an offshoot of the do no harm, but we can talk about that later.
Yeah, but it's always do no harm to your patient and not to the planet. And I think you're right. We need to extend that obligation to care to the natural world if we're going to make any progress.
Maybe the planet is our patient, or it should be. So
yeah.
Samir, we just heard about the role of individual physicians, the ethics there. What about leadership groups like the ones you belong to, Canadian Thoracic Society, Choosing Wisely? What should they be doing? Do they have an obligation to wade in here too?
I think they do, and I think we're already seeing good examples of it. Dr. Miller's Cascades organization is a great example. You mentioned there's Cascades is also affiliated with CAPE. This is another one, the Canadian Association of Physicians for the Environment. They do a lot of different projects, and those are groups that bring together physicians of different stripes. You also have Choosing Wisely, which you mentioned. That's an organization that kind of challenges different specialty societies to think about practices that may be wasteful in their own specialties, things that may be tests or treatments that maybe they don't need to be offering, that they do maybe out of habit or maybe out of sort of just tradition, and things that maybe we could do better. And so Choosing Wisely has sort of expanded that scope and challenged various specialty societies around the country to come up with recommendations for their own cohorts, for their own practicing providers, where they might reduce greenhouse gases or pollution related to practices that they perform that maybe they don't need to perform or can perform differently. And so that is something they've expanded to and sort of challenged all of us to think about, including the Canadian Thoracic Society. And as a respirologist, that's the group that I'm part of. And that group has also been very active, and for many reasons. That we sort of talked about all the health impacts, and patients with respiratory disease unfortunately bear a disproportionate burden of the health impacts of climate change. It's patients with asthma and COPD who are most affected by the pollution that we see from those wildfires. As we see tropicalization of these more and more northern latitudes, we're seeing longer and more significant pollen seasons, and it's that pollen that drives flare-ups in my patients with asthma and COPD. So those are the patients that are very affected by it. And so as an organization, this has become one of our priorities to talk about the impact of climate change on respiratory health, what can be done to mitigate that. And particularly there, in somewhat of a circular fashion, we are also the organization that produces guidelines for treatment of asthma and COPD. And one of the treatments is, as people know, puffers or inhalers. But the most commonly used type of inhaler, which is called a metered dose inhaler, uses a propellant that is based on hydrofluorocarbons. So it's a greenhouse gas propellant. So the very patients who suffer the most consequences from climate change, every time they have a respiratory symptom and they take a puff of their inhaler, are contributing greenhouse gases to that climate change. So this is something that at the Canadian Thoracic Society, we very much want to try to address and want to try to break that cycle of all that carbon being created as a treatment, as part of the treatment for that respiratory disease.
Yeah, there's a kind of paradox there, and we'll come back to it later because I want to ask you later about what individuals can do. And you hinted at one little thing, but we'll talk about some more later. Fiona, a lot of this is about sustainability, keep living, but doing it differently. You've talked in the past about the need for health professionals to see sustainability as a sign of quality. Can you reflect on that a bit? That's an interesting concept.
Sure. Well, I wish I could take full credit for it, but I really can't. I mean, the group that, in my view, got started on this is a small NGO in the UK called the Centre for Sustainable Healthcare that's been around since around 2008. And they did a really good job and really were among the first to start saying, look, it's not just about what the engineers do to run our buildings. It's really about clinical care, and it's deeply about quality. So in the UK, from around 2011, the Royal College of Physicians has added sustainability. Many of us use the Institute of Medicine's definition of quality, 6 dimensions, so patient-centered, equitable, effective, safe, timely. And then they've added sustainability as the 7th dimension to really help us think about how this is embedded. And we here in Canada, I think, my colleague Gillian Ritzie, who's from the Healthy Populations Institute at Dalhousie, working with Andrew McNeil, a surgeon scientist at UBC and Vancouver Coastal, with many other quality leaders here at U of T and across the country, have sort of imagined this a little bit differently, leveraging some of the terrific quality frameworks that have been developed by different provinces and territories to say, you know what, it's already present. That if our commitment to quality is a commitment to safety, then we've got to recognize that climate change creates enormous lack of safety that we have to react to, because it makes it's unsafe for patients, it's unsafe for our healthcare systems, they're threatened. If it's about effectiveness, which is one of our commitments in quality, then yes, it's about effective care, not low value care, appropriate care. If it's about efficiency and timeliness, then all of those kinds of issues that are embedded in quality are also about making our healthcare system more high quality and more sustainable. And issues like equity, which is also a core commitment in quality. We know, as has been discussed to some extent, that climate change is a threat multiplier. It has disproportionate impacts. It's an issue of deep injustice that the better off individuals and the better off countries. Canada is one of the highest per capita climate footprints in the world, including our healthcare system. And we bear fewer of those burdens, both as a country and as individuals. So there's an equity issue here in how we address climate change, as well as patient-centeredness, to really think about how folks are really partners in their care and have the capacity to act. So in ways that are going to be more sustainable and better care. So these are all already present as our core quality commitments. So I think it's really helpful to recognize that sustainability and indeed adaptation to climate risks and shocks is something that we've in some ways committed to. I think Ross is right to say, of course, that we haven't worked through the moral dilemmas of how do we make some of these broader commitments more central to our work. But I think that practically speaking, people can really hang on to that, make sense of that it's part of our quality commitment, and mobilize the methods, the mission, and some of the infrastructure that exists to make change in their settings.
And Ross, I think we've gone almost half an hour without saying the word COVID. I think that's a record for me in the last few years, but I want to break that now, because COVID, it was a lot of challenges, it was a big threat. We tested our resiliency, but I'm wondering, are there pandemic lessons that we can apply to going forward dealing with the climate crisis? Can we become climate resistant or resilient?
That's a great question, Andre. And so again, not wanting to be the dark one, having participated in all of the infectious disease, public health emergencies of international concern over the last 25 years or 20 years since they revised the IHR. I wrote a paper that the only lesson we learned from pandemics is that we don't like to learn lessons. So I think this time we ought to make good on learning lessons. One thing is to actually not see climate change and pandemics as distinct entities. They're interconnected phenomenon. As Dr. Gupta pointed out, that all of the most recent pandemics have been zoonoses, and so we need to take that animal-human approach very seriously. One of the strong contenders for new ways of thinking about pandemics, I think, also applies to climate change, and that's taking a more One Health approach, seeing the indivisibility, the interrelationship between animal health and human health. Also because agricultural processes and practices are, critical drivers of the carbon footprint. So I think once we start to, so the other thing that we learned from COVID that bears us some thinking about is, unfortunately, and during COVID, the health system itself became a vulnerable entity in the sense that we started to think about protecting the healthcare system during the pandemic rather than seeing it as a critical enabler to respond to the pandemic. And the Lancet Commission pointed out very strongly that we're going to need strong, resilient health systems to face climate change. So we're going to have to learn from where those vulnerabilities in health service delivery arose and sort of address them. The other thing we learned from COVID, which is going to be true for climate change, is that the impacts are differential. In other words, the vulnerability to climate change is not experienced equally across the population and indeed across the globe. So what we'll see is that, older adults, people who live in disadvantaged circumstances, the social determinants will play a massive role in how the health impacts of climate change play out. And similarly to COVID, we will see that there are, and it's a global health issue, that there are many health systems globally that simply lack the capacity to respond in a timely, efficient, and appropriate manner. And Canada, as a relatively rich nation, what do we owe to help our fellow citizens in countries that are far worse off than we are to help adapt to the challenges that climate change will pose?
Okay. And Samir, another thing we learned from COVID is people don't like change. They don't like anything that inconveniences them at all. But climate change is going to require a change in how we live. Now, you've studied this, how you make people change. That's notoriously difficult. Do you have tips for practitioners, people in the audience, and how you can make a change go a little more smoothly?
Yeah, I think, as you said, it's everyone's finds change hard. No one is immune to that, whether you're a practitioner or a patient in the context of healthcare. Some of the work that we've done has sort of really tried to focus in on this one thing, these, what we talked about earlier, these metered dose inhalers. And it doesn't seem like a big thing because there's very little carbon in every actuation. And that's some of the pushback we get is, is it really going to make a difference? But it adds up. One of those meter dose inhalers is the equivalent of a 110-kilometer car journey in a gasoline-powered vehicle in a year. And there are 800 million sold around the world every year. And there are 4 million Canadians with asthma and 2 million Canadians with COPD. So millions of Canadians use them. And we have an alternative. We have these things called dry powder inhalers that are that have about 1/10 the greenhouse gas footprint. And so the idea there, and what we've tried to do, is to analyze, what would happen if we replaced even a quarter of the meter dose inhalers with these dry powder inhalers. And it's not only just replacing that, it's also just, as Dr. Miller alluded to, it's improving care in general, because there are many aspects of care that right now are wasteful and lead to unnecessary prescriptions of these meter dose inhalers. Many patients with asthma and COPD, whom we've diagnosed and started on therapy, don't actually have the conditions, but we don't do enough testing to determine that. So a lot of those patients don't need these inhalers. Many of those patients aren't on the right sort of baseline chronic therapy to keep their disease under control. So they tend to reach for their so-called rescue inhaler often and puff away on that and release those gases each time. And so if we fixed all of that, the analysis showed that the cumulative impact is quite large. We're talking about 450,000 metric tons of greenhouse gases reduced every year just from fixing these problems in asthma and COPD. And that's the equivalent of taking off 100,000 gasoline-powered vehicles per year off roads. And that's, for context, that's not dissimilar to the number of electric vehicles that are registered every year. And we think about how much we talk about electrifying transport versus how much we talk about changes in healthcare and the cumulative impact. I think some of that information starts to become powerful when you're trying to change behaviors. I think the other thing is that, when you talk about healthcare behaviors, it's a very challenging time, particularly, and Dr. Upshur talked about the impact of the pandemic on an already strained healthcare system and how much we all heard about during the pandemic, burnout, healthcare workers leaving the system, feeling underpaid, underappreciated, overworked. It's very hard to go to a healthcare workforce right now and say, and they're barely treading water. Often they're barely just able to deliver that level of care that they feel comfortable with. And to say, I need you to do something extra. I need you to do that extra little bit, be a little more thoughtful, take a little more time to think about the environment. Well, that might just be the straw that breaks the camel's back. But what we have found is that unlike other initiatives where you're trying to improve quality in general, this one resonates differently. And I think it's because there's a lot of what's called eco-anxiety or climate anxiety out there. And physicians tend to be climate conscious, whether it's nature or nurture, whether it's the type of person that goes into medicine or something about our training and how it molds us, and the effects we see of climate change in our patients. But we tend to be very conscious of it. And physicians, anybody in healthcare really, I think, has a degree of climate anxiety, climate consciousness, and empowering them with a way to do something about that in their everyday practice, in their everyday life, can be very powerful. So if we use that and we frame it as a way to address that, this is something small you can do that'll help with your own climate anxiety. We have found that to be quite powerful. And similarly with patients, particularly young patients, Gen Z patients. This is the climate anxious generation. They're worried about their future, their children's future. If you empower that patient and say, it's a small thing you can do. You can switch out your meter dose inhaler for this dry powder inhaler. You have to learn a new device and you have to be comfortable with it and spend a little bit of time, but you've done something for the environment. And that will help to allay your own eco-anxiety. And that can also be very powerful. So I think framing it in that way can really go a long way, both with providers and with patients.
And Fiona, talking about empowerment, we have a U of T audience here. We should talk a little bit about what's happening internally. You're part of a new interdisciplinary unit. Temerity Medicine is part of this. What's the university doing to address climate sustainability, resilience, related things?
Well, gosh, where to start? I think this is a really good illustration of exactly the kinds of extraordinary expertise that exists within Temerity Medicine, and also within the other founding faculties that are part of this new initiative that's the Collaborative Center for Climate Health and Sustainable Care. So it's medicine, it's public health, it's nursing, and it's pharmacy. And so what we're getting today, I think, is just a snippet of the kind of expertise that already exists within our health science faculties, and then the need really, which is what Temerity is doing now in collaboration with the other three faculties, to sort of bring that together to create not a new department, not a new sort of rigid academic structure, but the kind of academic structure that is enabling of the existing missions. So I'm not a clinician, but my clinical colleagues can speak to the needs for change in health professions education. There are things that surgeons are going to do differently, that respirologists are going to do differently, that family physicians are going to do differently, that nurse practitioners, pharmacists, both in hospitals and community pharmacy, and nurses across the sector are going to do differently. So health professions education, and our trainees have been telling us this for a long time, is already adjusting, but there's a lot of work to do, and we can collaboratively support that so that there can be a deeper and more rapid sort of uptake of new information for, as I say, what's already happening, but deepening at the undergraduate and postgraduate level. Research, there's lots we know, but lots we don't know. So I think this is the kind of unit that's going to help bring the moral philosophers together, with the clinicians who are grappling with these difficult questions, and the engineers the material scientists, together with the, the lab pathology medicine folks and the respirologists as they think about a new device or a new practice. So it's got that kind of thing. And then I think the other thing that we have here at U of T that's really quite extraordinary is the Academic Health Science Network. So Toronto U of T is sort of part of an extraordinary academic health science network that spans the cities of Toronto and Mississauga, 14 academic hospital corporations, a really strong academic primary care network housed within the Department of, or networked to the Department of Family and Community Medicine in Temerity. And it's there also where we have tremendous potential to collaboratively, test and improve practice and think about policy development, particularly around how healthcare can adapt and support community resilience in the context of climate shocks and stresses, but also improve practice and connect nationally. So it's a very, very exciting initiative that really, comes on lots of efforts across lots of faculties and departments and the kind of expertise that I think you're seeing here today.
I think a good reminder, this is everybody's lane, right? It sounds like everybody has to be involved. So Ross, I wonder if you could tell us a bit about the role of technology in this. I saw an example of something, the air quality health index for people with COPD, for example. Can you talk about that as an example of technology helping out?
Yeah, so I'm always a bit reluctant to talk about respiratory illness in the presence of a respirologist, but this was a small project that was hatched with a colleague of mine, Alan Abelson, who's done a lot of work with the Air Quality Health Index with Environment Canada and the World Health Organization. And what we thought was there was a need to sort of leverage. So one of the strengths of the Temerity Faculty of Medicine and the university is it's a kind of trusted source. So people trust their family physicians. And we were concerned that people who are vulnerable to the health impacts of adverse air quality days weren't getting the message. So what we devised was using, text messaging from a cell phone that came from the family physician. So it would notify the patient that the next day was going to be a potentially adverse air quality day. And we got through, again, this network of primary care researchers. We were able to identify patients in practices with COPD and asthma and heart failure who might be potentially adversely affected by poor air quality. So the Air Quality Health Index goes from 0 to 10. The higher it is, the worse the air quality. And when it gets past a certain threshold, the message is to change your activities. Now, it doesn't help. So the idea here is to get preventive. I'm a specialist in preventive medicine, so you want to go upstream of the cause. So to let people know in advance that they might need to change their behavior the next day. So that was a start. And then we thought, pollens, why don't we alert people about pollen days or heat days or cold days? And when it was really icy, I used to run to my practice early because most of my patients are very old and tell them, don't come in. It's going to be, it's an orthopedic day. I'll talk to you on the phone. So how can we use technology to communicate with at-risk patients, but also communicate with clinicians? So I would envision this expanding to let clinicians know that there's been an adverse air quality day. There's a bit of a lag time between when the adverse air quality day is and the clinical event. So here's what you should expect if you're a patient. Here's what you should expect as a clinician. Put that in place, evaluate it, and see if it works. So that's one idea of how to use technology to sort of get ahead of some of these impacts. Doesn't deal with the root causes, but it does help with mitigation.
Speaking of technology, my clock's telling me we're almost out of time. I always like to end panels, though, on a hopeful note, especially in these dark times. So I want to ask each of you, give me a hopeful message going forward. How are we going to do better on the climate front? What makes you hopeful? And maybe Ross, you've been the darkest. Maybe you could kick us off on this one and say something really bright tonight.
Well, I still have faith in human intelligence and the fact that once we see a collective challenge, we'll find a way to use our collective resources to find a way. We're up against the wall for sure, but I wouldn't get up in the morning and come to work if I didn't have hope that at the individual level and at the collective level, we couldn't make a difference. I think it's going to be hard work, but I think it's possible.
And Fiona, where do you find hope? How can you give some hope to the eco-anxious in our audience?
Well, you know, I mean, I'm following from what Ross said. One of the main reasons why I do work on healthcare is because I like to say that the social footprint of healthcare is much bigger than its carbon footprint. It touches a lot of lives. It affects a lot of people. There's a lot of engagement and capacity to connect with communities, to connect with individuals in the workforce. So I think that it's a really important social institution that can demonstrate our capacity to care for each other. I mean, it's one of our strongest social institutions in terms of providing in accordance with need, not ability to pay. So it has a very, very important role in building collective capacity, as well as the sort of practical things that we need to do through healthcare. So that gives me, it's really why I think it's so important for healthcare to be a visible agent of change.
And Samir, the pressure's on you to send people home with a hopeful message.
I have to say, I'm a lot more hopeful after this session, Andre. I've learned a lot, and I'm just energized by hearing what Dr. Miller and Dr. Upshur have to say, and by knowing that, you know, some of the brightest minds are on it. You know, they're on this problem and they're very motivated by it. And I think people around the country are motivated in healthcare, whether that's providers or patients. And that gives me a lot of hope because, as you've heard, when intelligent, dedicated people roll their sleeves up and get to fixing a problem, the problem gets fixed. So there's a lot of hope.
Great. Always good to end on that word. That concludes today's Temerity Medicine Talk. Thank you again to our guests, Samir Gupta, Fiona Miller, and Ross Upshur. For those watching live, you'll see a link to the brief survey in the chat window. We'd appreciate you taking just a couple of minutes to provide some feedback on today's event so we can do better events in the future. And we hope to again to see you at the next Temerity Talk. Thank you. Take care.